Hello there. We're going to start in 1 minute so that we can tackle some key, tackle our 5 presentations and then send you on your way after a 2-day conference. Before we have a few more seconds before we start, I'd love to hear quickly, what do you think of the last 2 days? What's it been like? Your brain full? Empty? Well, we hope the last 2 days have been very interesting and stimulating for you. My name is Dani Patello. I work at the National Institute of Mental Health, and I would like to welcome you to the very last session of the day. And this is our second session. Yesterday we had a session on dissemination and implementation science, and this time we have a second. There were so many great applications or abstracts. We now, we put together a second session today, and we have 5 great talks. All of them spend, as you know, about 15 minutes each, addressing the studies that they have. But we have a range of topics and research designs. We have, one prospective design. We have a retrospective design. We have a longitudinal design, collaborative care, team-based model, and then we have an interesting paper on mental health, or policymakers' perspectives on dissemination of mental health services. So I want to invite you to ask questions at the very end of the panel, and let me go ahead and turn it over to our first speaker, Hayden Haskin.
Thank you. I'm really happy to be here today sharing some preliminary findings from our study. So pharmaceutical spending is an important driver of healthcare spending growth, and understanding variation in diffusion patterns and in use of new technologies like new antipsychotic medications is important as we seek to try to improve the value of healthcare in the U.S. When the second-generation antipsychotics first came on the market in the 1990s, they were an important innovation because they had at least similar efficacy to the first-generation drugs, which at that point were almost exclusively generic and thus carried a lower price. But they also had a lower risk of some pretty problematic side effects, like extrapyramidal symptoms, or EPS. Over time, we learned that many of the SGAs also carried a high risk of metabolic side effects, and thus their clinical benefit relative to those first-generation drugs was less clear and likely varies across patients. There are 3 primary types of new SGA entrants during the period we studied, 2008 to 2016. The generics, the new orally administered brands, and new long-acting injectables. And much of the prior research in this area has focused on identifying patient characteristics associated with SGA use, or focused on diffusion of a single drug. We know little, though, still about practice characteristics that are associated with prescribing these new types of drugs, and that's our focus. Here are the drugs, the SGAs, that entered the market between 2008 and 2016. And if you look at the left panel, this is the generics, and the first generic entrant, risperidone, came out in 2008. And then all of that original group of SGAs followed during our period, as you can see. Most of them, all but aripiprazole and ziprasidone, fall into the moderate or high-risk categories for metabolic side effects. In the middle are the 6 new brand drugs that came out during that period. All but Versacloz, which is a reformulation of clozapine, are new molecules that are in the lower risk categories for metabolic side effects. And most also have the low risk of EPS that those earlier generics did as well. And then finally on the right are the 4 long-acting injectables that came out during the period. So now prescribers had a choice beyond Risperdal Consta of SGA injectables. With this work, we sought to characterize the diffusion of new SGAs that were introduced during this period by type of product. And then second, given that the locus of accountability is increasingly the practice or the provider organization with new payment and delivery models that are being experimented with, we wanted to identify practice characteristics associated with the diffusion of these 3 types of SGAs. And then finally, we wanted to quantify within practice correlation of diffusion times across the 3 types of entrants. We use Medicare Part D claims to identify beneficiaries filling at least 1 antipsychotic prescription, the associated prescriber of those, and then that prescriber's specialty. We use the MD-Pass data to identify the primary medical practice associated with the prescriber. And we did that by using the prescriber's NPI from the antipsychotic claim and linking it to a tax identification or number or TIN, which is our definition of a practice here, using this data set. We use the Part A and carrier files to determine practice and patient characteristics, and then the American Community Survey to give us information on poverty in the area of residence for a practice's patients. We focus on all adults enrolled in the traditional fee-for-service program who fill at least one prescription for an antipsychotic during our study period. And that means both those that had a diagnosis for an FDA-approved indication and those that didn't in the claims. And the practice is the unit of observation here, and we include all practices that are associated with the prescriber that wrote a filled antipsychotic prescription for a beneficiary in our sample. In examining the diffusion time by type of SGA, we consider month 0 in these models that we'll be estimating for each of the 3 groups, the new generics, the new brands, and the new injectables, to be the date of the first entrant in that group. And then our main outcome of interest is the number of months from the first entrant's introduction until the cumulative share of all of a practice's antipsychotic prescriptions that are for that new group of drugs is 10% or greater. So we're looking at what we're calling time to routine use in a practice, defined as at least 10% of all antipsychotic prescriptions for the practice being dedicated to that new group of drugs. We first create practice-level characteristics using data on all of a practice's patients from the baseline year. And then to estimate time to routine use for each group of SGA entrants, ideally we'd estimate a frailty model. That is, we'd model all 3 processes at once with a random intercept for each practice. But with the sample sizes we have, which are basically around 100,000 practices and over 5 million beneficiaries in the Medicare files, that's not possible to do on the VRDC, the virtual data network for CMS. So we implemented a 2-stage strategy. We estimated separate Cox models for each group of SGAs, computed the residuals, and then examined the relationship among the residuals using Pearson correlations. And then finally, we look at characteristics of beneficiaries filling a new type of entrant versus those that never fill that new type of entrant and see how they're different. So we identified, as I said, over 5 million beneficiaries during this 9-year period that filled at least one antipsychotic prescription. And we were able to link 93% of them to about 144,000 medical practices, or in this case, it's defined as TINs. The other 7% didn't match at all for any of their prescriptions, or they were partial matches, meaning that the NPIs for only some of their prescriptions matched to a 10. And so at least in this first round of results I'm going to show you, we estimated our models just on the 93% that we had complete matches for. Here's some descriptive information on the practices that we identified that were prescribing antipsychotics during this period. So it's just over 100,000 for each type of SGA entrant, after we imposed various restrictions like the patient age requirements, and we needed to make sure that each practice was active during the baseline year so we could observe characteristics of their patient population and so on. You can see on the left the mean numbers of patients and providers in our practices. The mean share of psychiatrists relative to all billing clinicians for a practice is only about 9%, although there's a fairly large standard deviation there. This reflects the fact, I think, that many of these drugs are being prescribed in primary care practices today. On average, the mean percent below poverty for the zip codes of each of the practice's patients is about 12%. And on average, about 8%, if you look at the right, about 8% of a practice's patients had a diagnosis of psychosis defined as either a schizophrenia or bipolar diagnosis. Here are the diffusion curves for time to routine use for the generic entrants. So the blue line at the top shows a practice's time to routine use for any one of the new generics, and then you can see the individual drug lines in different colors. By the time that the second generic entrant, olanzapine, enters in 2011, risperidone was already being routinely used, generic risperidone, by 50% of practices that prescribed antipsychotics. So its take-up was pretty rapid. Subsequent generic entrants, you can see, they got to routine use at a relatively rapid rate. but never reached the same level that risperidone did by the end of our study period. Among practices that ever prescribed a new generic, as you can see up here, the mean time to first use for a practice was 21 months for these generics. And among practices that reached 10% use for the new generics during our study period, the mean time to 10% was 24 months. Things look pretty different for the new brand entrants. So, for example, by the end of our study period, Latuda or lorazepam is in routine use, meaning by our definition again, for 10% of a practice's patients getting antipsychotics or more, it was used by lorazepam was used. It was in routine use for only about 2% of practices. The vast majority of practices prescribing antipsychotics never get to 10% use for any of the new brand drugs that came out during this period. And then again, as you can see up in the top right, among practices that use any new brands, time to first use is quite a bit slower than for generics, 44 months on average. And for the practices that reached the 10% mark, time to 10% was 57 months. And here are the long-acting injectable entrants. Only 1% of practices, if you can see the scale is very different over there, only 1% of practices reach 10% use for the new injectables, which makes sense given the nature of these drugs. You wouldn't expect most practices prescribing antipsychotic drugs to use these drugs routinely. But among those that do, time to first use is 40 months on average, and time to 10% use was 49 months. Here are results from the Cox models that we estimated on time to routine use. The hazard ratios that you're seeing here report the risk of 10% cumulative use for a 1 standard deviation increase above the mean in the covariate, holding the other factors constant. So for example, if you look at the second row, oops, oh goodness, didn't mean to do that. How do I escape? Oh, got it, sorry, I'm sorry. If you look at the second row, percent below poverty under the injectable column, and you see a 1.13, increasing the percentage of patients from below poverty areas by 7.6%, which is 1 standard deviation from the mean percent poverty, increases the practice's risk of routine use of new injectable drugs by 1.13 times. So you can see a number of characteristics, the ones in bold here, of the practices are associated with use of new entrants of each type. So for example, as the share of black patients for a practice increases, the risk of routine use goes up for both generic and injectables. As the share of psychotic patients in a practice increases, so does the risk of routine use for generic and injectables. And as the share of dementia patients increases for a practice, the risk of routine use of the generics goes up, but the risk of routine use for new brands and the injectables goes down. And I'm just highlighting a few of the results we see there. Here are the pairwise results on within-practice correlation of time to routine use across the 3 types of SGAs. You can see that if within a practice, the correlation between time to routine use for generics and brands there's a small negative correlation there. Same for the generics and injectables. The correlation, there's a small positive correlation between the diffusion times for the new brands and the injectables within a practice. But the diffusion times across the board for these 3 groups are only weakly correlated, as you can tell by these numbers. Finally, I wanted to just show you some initial results on beneficiary characteristics measured during the year that the patient receives their first antipsychotic prescription. And it's for individuals who used at least 1 new entrant of a given type versus those who never used that type of new entrant. So the users of a given type of new entrant, for example, the new generic users would show up in the column greater than or equal to 1, meaning that they did try a new generic drug. So if you look, for example, in the first row, no mental health diagnoses in the claims in that first year of their prescription, you see that 57% of new generic SGA users had no mental health diagnoses during the year versus just 28% for the new brand users and 21% of the new injectable users. If you look at the next row, any psychotic diagnosis, 21% of new generic users had a diagnosis of psychosis in that year versus 51% of new brand users and 74%, much higher numbers, of the new injectable users. If you go to the dementia column, About a quarter of new generic users had a dementia diagnosis versus just 4% of new brand users and 2% of new injectable users. And one more I'll highlight, the psychiatrist prescriber column. The proportion of new brand and new injectable users that had a psychiatrist prescriber is higher than the proportion of new generic users. So we definitely see some initial differences here just in these raw data in the types of patients who seem to be using the different types of new entrants that we want to explore further. So as I said, these are just our preliminary findings thus far. We still have a lot to do, which I'll get to in a second, but so far we found that the diffusion of new brand entrants is slow relative to new generics, and few practices seem to be using the new brands or new injectables routinely. I think the new brand finding in particular is interesting, given that the newer brands include a number of options that have both relatively low risk of EPS, but also relatively low risk of metabolic side effects. And that's in contrast to the generics that were out at the time. So just generic aripiprazole, which came out at the very end of our study period and wasn't really present for most of this period, and ziprasidone, which is less commonly used because of other risks that that drug carries. Those are the only two in the low metabolic risk group among the generics. Yet we still, during this period, didn't see much use of these new brands, which for some patients at least did seem to have some advantages, for those who are more susceptible to metabolic risk, perhaps. So some of this may reflect coverage policies of Part D plans, which have incentives to encourage generic use where possible. Even though antipsychotics are a protected class, plans can impose various requirements like prior authorization or step therapy that can affect use of the drugs, and that's something we haven't been able to look at yet. We found that routine use of the drugs in these three categories was associated with a number of characteristics of the practices, like the examples you see here. But as I said, we have several more things that we need to do. One is we want to build on results of the last slide by estimating patient-level analyses of the probability of using these new entrants for each of the three types. So far, we've only looked at within-practice correlation across the three types taken as a group. But next we want to look at within-practice correlation within a group. So what's the correlation of diffusion time for the different generics within a practice or the different brands? If you adopt one early, do you adopt them all early? We want to do separate analyses for the under and over 65-year-olds. And our next step on the injectable analysis is a sensitivity analysis where we would look just at those who get an injectable and see if our results are similar versus looking at everyone who gets an antipsychotic. So I'll throw up my email address. I'm very sorry, I am having some flight issues and I have to leave now, but I would welcome anyone to email me if they have questions or comments or want to talk about this work. I would love to do that. So thank you so much.
Let's see if I can. Maybe help me find where I am here. Right there. Yeah. Thank you. All right. Well, thank you. And thank you for everybody who is staying until the end of the meeting and attending our program. I am going to stick with my time here, 15 minutes. I do follow directions well, so most of the time. I'm going to talk about a clinical trial that has recently been completed, and actually this is in press. Should be published in the September issue, I think, of the journal Clinical Psychiatry. So do feel free to reach out to me, but hopefully you'll be able to see the full report at that time. This is a 6-month prospective randomized controlled trial of an intervention that our team at Case has developed over the last decade, customized adherence enhancement versus bipolar-specific educational control in poorly adherent individuals with bipolar disorder. You have my disclosures. So I just want to set a little bit of the background and context and talk about medication adherence. I'm going to be talking specifically about adherence with medicines. We know that adherence is important in a variety of different interventions for people with mental illness, but I'll be focusing here about medication specifically. Adherence is typically described as a proportion, often quantified as a percentage of medication taken over a given time period. So it's the proportion of medication that's actually taken versus what the prescribed or the targeted amount is. Adherence is rarely all or none. And if you look at the adherence literature in serious mental illness in particular, the threshold that's usually accepted and is pretty much a consensus is 80% as being good enough for most of the psychotropic medications that we prescribe for people with schizophrenia, bipolar disorder, or severe recurrent depression. So not missing more than 20% of medication. Dosing thresholds can be assessed, but for most of our psychiatric medications, they are not a current standard of care. There are a few exceptions. Lithium, some of the anticonvulsants for mood stabilization in people with bipolar disorder. But for the most part, we're really looking at standard dosing ranges rather than kind of personalized medicine where we follow serum levels or some other biomarker for a given individual. Non-adherent rates vary across psychiatric diagnoses, but you see that there's a fair bit of commonality and overlap for conditions that we would call certainly serious mental illness, severe recurrent major depression, bipolar disorder, and schizophrenia. So a good rule of thumb is most patients, if you look at big databases, take their medication about half of the time. So that's kind of where we are in general. The literature suggests that there are some general predictors, patient characteristics or individual characteristics or setting characteristics that may predict poor adherence versus good adherence. So people who have excellent symptom response, good response to medicine tend to be more adherent. People who have minimal side effects, individuals who have later onset illness where perhaps they've developed some ability to sort of manage their life in general and their health in general. Women tend to have better adherence. People that have good insight into sort of what the benefits of treatment might be, and then the opposite characteristics might predict worse adherence. Substance use goes along with that, poor health literacy, and people who have drug side effects. This is some data that we pulled a number of years ago from the VA, which has medication adherence that can be calculated using something called the MPR, medication possession ratio. And that's basically a proportion of drug fills based on pharmacy refills. So the important caveat with MPR is that even though somebody fills a prescription does not mean that they actually ingest that drug. And talking with some of my VA colleagues, where they have these automatic refills, every 30 days or every 90 days, that there are definitely individuals where, if you do a home visit, you'll see like, a drawer or even a room that's just like full of boxes of unopened medication. So they could have an MPR that's 1, which means perfect adherence, versus 0, which is no adherence. And you can see, looking at different mood stabilizers here, this is lithium, carbamazepine, valproate, and lamotrigine, that the MPRs are running around 80%, 0.79, 0.80, not very much difference across different mood stabilizers, in spite of the fact that these drugs have different mechanisms of actions, different side effects. And that kind of goes against the clinical lore that the medication side effects really drive adherence. And that tends to be what a lot of clinicians think. Our patient data really suggests that side effects are important, but clearly not a key driver. There are other ways that you can look at adherence other than NPRs. So there's a variety of adherence rating scales. I've listed some of the common ones that are out there. The thing that's important to realize about standardized rating scales for medication adherence is most of them are looking at attitudes toward medications rather than specific adherence behaviors. So it's important to separate those two constructs, what somebody thinks about their medicine, and that's important to know, versus actually when they're taking or not taking. And so these are really adherence attitude measures rather than actual behaviors. So refills, pill counts, asking somebody about medications is clearly important. Actually, maybe before I go to the reasons for adherence. So self-report, asking a person if they took their medication, is one of the most common ways that we have to evaluate medication adherence. And that's what most clinicians do in clinical settings. Do you take your medications? There's data that suggests that self-report will under-detect poor adherence. So people will say, oh, I take all my medicines, and that may or may not be true. The data suggests that under-reporting is common. What the flip side, though, is generally the data suggests, based on where we can look at serum levels, if somebody tells you that they are not taking their medication, you can probably take that to the bank. All right, so measuring adherence is it's complicated, but one of the things that makes both measurement and interventions complicated is that there are a bunch of reasons why people take or don't take their medication, from patient-related factors, environment, delivery systems. You heard in the previous talk about long-acting injectables. That might be a way to get through some barriers, psychosocial treatments, therapeutic alliance, cultural compatibility. So there's a host of reasons why individuals may choose to take or not choose to take their medications. And that's that reason for adherence or non-adherence is what we've built our intervention on. We've developed a program called Customized Adherence Enhancement, or CAE. It's a modular, flexibly delivered behavioral intervention to improve adherence in high-risk people, specifically with bipolar disorder. We have 4 different modules: psychoeducation, medication routines, communication with providers, and substance use. These are all based on evidence-based practices. We had NIMH funding to conduct a prospective 6-month randomized controlled trial. So we actually screened and we enrolled people with bipolar disorder who are identified, self-reported poorly adherence patients using that 80% threshold. So they had to be missing at least 20% of their bipolar drugs at study entry. Then we enrolled them at baseline, we randomized them 1-to-1, and people got either our CAE intervention with the flexibly delivered modules, a total of 5 sessions, or a pretty high-intensity bipolar-specific educational intervention. So also attentional and time-controlled, and then our outcomes were evaluated at 3 and 6 months. Our primary outcome was adherence change, self-reported adherence change, as measured with the Tablet's Routine Questionnaire, or TRQ. This is something that's been used broadly in bipolar adherence research. We validated or tried to validate it with MEMS caps, so these are automated pill caps. Other outcome variables include bipolar symptoms measured with the Brief Psychiatric Rating Scale, or BPRS, mood symptoms with the Young Mania Rating Scale and the Montgomery Asperger Depression Rating Scale, and Global Assessment of Functioning, or GAF. We had 142 people were randomized, half to each arm. The average age was around 47, almost 69% women. That's pretty common for adherence trials, and definitely a challenge for the future is to try to enroll, as you can imagine, the people that are the worst, most poorly adherent are not the ones that are going to step up to the plate generally and say, I want to be in an adherence trial. So that's one of our challenges. We did have good minority, at least racial minority participation, almost 67% African American. Most people had had bipolar disorder for a couple of decades, so these are not, new recruits to bipolar treatment. A lot of psychiatric comorbidity. At screening, the average proportion of missed drug was around 50%. So 48% within the past month, 55% within the past week. All right, so our outcomes, our TRQ, I'm very thrilled to be able to say that we hit our differentiation between CAE and EDU, both on the TRQ past week and TRQ past month. So even against a very rigorous educational bipolar specific control. Our CAE intervention delivered improvements above and beyond with respect to treatment adherence. Looking at other variables, our 6-month GAF, adjusting for gender, age, marital status, and race, was also statistically significant, favoring the CAE intervention. We did see mental health services use actually increase a little bit in both arms. Maybe learning more about bipolar disorder might have helped people to feel like they wanted to use other services. There was less service use actually in the CAE arm compared to EDU. Global BD symptoms were similar. We did find that in this RCT, different from our pilot work, symptom levels were actually kind of low to begin with. So these were people that were not terribly functional, but they didn't have, say, a lot of manic symptoms, and it was kind of low-grade depression that was particularly problematic. Also problematic was MEMS. So, monitoring adherence is tough. 2/3 of our sample did not bring their MEMS caps in with follow-up. Maybe that's what happens when you try to enroll the bad boys right from the beginning. But we have been exploring different automated ways of looking at monitoring and certainly have learned some things through this trial. So we're using some different technologies at this point. But in conclusion, I believe that our CAE approach demonstrated by this trial and our other preliminary work is that it is acceptable to people that are not typically enrolled in research studies, and it can enhance medication adherence. If we think about this in the broader health services perspective, we can do a take on the Institute of Medicine's 3-tiered approach. Think about enhancing psychotropic adherence. So universal adherence enhancement interventions would be things that we give to everybody. This would be psychoeducation, customized dose schedules, kind of what they do really, really well at the VA, and they send you a regular, supply of medication. So if you lose it, you get a new supply next month. Selected adherence enhancement interventions would be given to people at risk. So you might do things like embed something into your electronic health record and identify people who aren't refilling their medicines on time, and include some motivational interviewing or environmental supports or prompts. And then you might have something like indicated anti-adherence enhancement interventions that could be administered to people who are at the highest risk. Let's say, for instance, somebody who's had a hospitalization related to poor adherence or relapse related to poor adherence. So that might include home visits. I think our CAE intervention probably could be a very reasonable approach to take with both of our bottom 2 levels here, certainly. Just to take-home message, I would say that assume generally, what the data says is assume suboptimal adherence in most people with chronic mental health conditions. It is important to identify attitudes toward treatment and medication. Personalizing and delivering an intervention that maps onto a person's individual reason for taking or not taking a medication appears to be important. And also remembering that adherence is a process. It's not a one-time thing. It needs to be continually monitored and continue to be addressed. And we are, at this point, investigating how we might scale up CAE in different settings and potentially to different subpopulations. And I think that's all I have. Thank you very much.
Hi, everyone. My name is Katie Nelson. I'm a doctoral research fellow at the Dornsife School of Public Health at Drexel University. And kind of switching gears a bit, I'll be presenting a study about where state legislators turn for behavioral health research, what their dissemination preferences are, and how these vary based on political party. And so this is part of a larger R21 that's being conducted by Dr. Jonathan Pirtle, who unfortunately was unable to be here today. And I'd also like to acknowledge our other collaborators on this study out of the Brown School at Washington University, St. Louis, and UPenn. Also, the work that I'm about to present was recently published in Psychiatric Services if you need any additional details or want any additional details. So how do we translate behavioral health research into policy? So broadly, this study and the larger project as a whole act to understand how we can more effectively translate behavioral health research into policy, specifically policies on a state level and policies made by state legislators who are elected officials. So as we've all seen and heard over the past few days, there's a lot of great behavioral health research being conducted, and often this research sits mostly on shelves or in journals or on servers or the internet. So ultimately, we were interested in how to improve this translation of behavioral health research into policy decisions. So just a little bit background and context. There are over 7,300 state legislators in the US, most of whom have no specialized content expertise on behavioral health. Yet the decisions that they make have really strong implications on the architecture of state behavioral health service systems. So such decisions relate to how tax revenue is allocated and spent on services, and the regulation of insurance markets within the context of state parity laws. So state legislators can really improve the quality of behavioral health systems when they make evidence-informed decisions. But unfortunately, we know that research evidence typically has relatively limited influence on legislators' decisions as related to behavioral health and other health issues. So the issue of evidence-based decision-making is very complex due to things like politics or lack of policy-relevant research findings. But there's really no silver bullet to the problem. Part of the problem that we see is a dissemination problem. So the passive modes of evidence dissemination that researchers typically use, like publishing in journals or giving presentations at conferences such as this one, are generally not effective at reaching policymakers or decision makers. So the evidence is not getting to them. And another side of the issue is that how research evidence is formatted is not generally that compelling to policymakers. So often as researchers, we have these one-size-fits-all approaches or strategies. So we write articles that are very data-focused or very text-heavy. And so how we package our evidence is not particularly clear or compelling to policymakers. So a possible solution and a way forward to address these issues is dissemination science. And dissemination science, defined by the NIH in the Dissemination and Implementation Research Program announcement, is the scientific study of targeted distribution of information and intervention materials to a specific public health or clinical practice audience. So in this case, our audience is state legislators. And the intent is to understand the best how to best spread and sustain knowledge and the associated evidence-based interventions. So the idea is that if we disseminate evidence in ways that reflect legislators' preferences for how they want to receive information, then we can improve evidence-informed decision-making. But formative research is needed to inform the design of these dissemination strategies. And unfortunately, this formative research is lacking. So there was a systematic review that was published in 2015 in Psychiatric Services, where they scanned the evidence for what we know about strategies to increase the use of evidence in mental health policymakers. And they found that there was little research in this area in general, and that there was nothing focused on state legislators in the US. So the current study sought to address three very specific knowledge gaps. One is, where do state legislators turn for behavioral health research when they're making policy decisions? And information about this can inform the channels through which and the sources through which researchers disseminate behavioral health evidence. And it also isn't clear which features of behavioral health research are most important to legislators. So when they get evidence, do they want narratives? Do they want personal stories? Do they want economic evaluation? Do they want it to be specific to their jurisdiction? What is most important to them when getting disseminated materials? And again, information about this can inform how behavioral research is packaged and then communicated. And then lastly, no studies focused on disseminating behavioral health research to policymakers have explored differences by political party affiliation. And this matters because we know that polarization is increasing in US state legislators. And we also know from public opinion research among the general public that Democrats and Republicans have different attitudes towards behavioral health, with Republicans generally having more stigma towards people with behavioral health conditions than Democrats, and Republicans being less supportive of spending on behavioral health services. So understanding how Democrat and Republican legislators might differ in their dissemination preferences can inform how dissemination strategies might be tailored for audiences with different political party affiliation. And so the specific aims of the current study were to, 1, determine where state legislators seek behavioral health research, 2, identify the features of behavioral health research that are most important to legislators, and 3, assess differences in the research-seeking practices and dissemination preferences between Democrats and Republicans. And as I said, this is part of a larger study that's focused on dissemination of behavioral health evidence to state policymakers. So a little bit about the methods. These data were from a survey that we fielded, a cross-sectional survey that we fielded in March to September of 2017. It was a multimodal survey. We mailed letters to legislators telling them about the survey. We also mailed them 2 paper-based versions of the survey with postage paid return envelopes. We also emailed them a whole bunch, and we called them up to 15 times. So we pretty much did everything that we possibly could to get this sample of legislators to complete the survey. All that said, we got a response rate of 16.4%. So this was much lower than what we had hoped for, but it's still much higher than what other people have gotten in surveys of state legislators recently on health issues. Another good thing is that we knew quite a bit about the non-respondents. So we knew their gender, we knew their political party, we knew their geographic region, and with this information, we were able to calculate and apply non-response weights. So our dependent variables were where legislators turn for behavioral health research and important features of behavioral health research. And so the items that we used, which I'll describe in the next slide, were adapted from Karen Bodenschneider's work, where she studied state legislators and administrative policymakers' research preferences related to social science issues, so not specific to health or behavioral health issues. So we asked, where do state legislators turn for behavioral health research? So if you're going to seek out mental health or substance abuse research to make a policy decision, who would you turn to? And we had a list of 9 options, and they could choose up to 3 of those options. And then for information, for important features about behavioral health research, we asked if you were to receive mental health or substance abuse research, how important would it be, if at all, that the research have each of the following characteristics. And then you'll see in the subsequent slides that we had about 8 different characteristics. On each one, they reported on a 5-point Likert scale how important that feature was. And so we dichotomized these variables so that the ratings of 4 and 5 were coded as very important, and ratings of 1, 2, and 3 were coded as not very important. So the primary independent variable was political party. And again, this analysis was descriptive and exploratory, so we used very straightforward univariate descriptive statistics and bivariate analysis comparing Democrats and Republicans. So some results. So where do legislators turn for behavioral health evidence when making policy decisions? So advocacy organizations, legislative staff, and state behavioral health agencies were the primary sources. And then you can see down the tail were university researchers and industry, such as insurance companies. So then when we stratify by political party affiliation, we see some interesting differences. Democrats were more likely than Republicans to turn to advocacy organizations, so 65% versus 40%. And also, Democrats were more likely to turn to university researchers, so still a lower percentage than I think we would all like for both parties, but difference of 34% versus 19%. And then Republicans were more likely to turn to industry sources. So still the least frequent place for Democrats and Republicans to turn for resources, but the percentage of Republicans saying that they would turn to industry was significantly higher, so 6% versus 16%. So next, what features of disseminated behavioral health research do state legislators see as very important? And we found that the answer to that question is economic evaluation data. So not really surprising to anyone who was listening to Dr. Nitzer's talk earlier and how the Wall Street Journal, when it picked up that ROI information on his study, how that really skyrocketed and brought it to the attention of a lot of people. 82% of state legislators said that disseminated materials providing information about budget impact and cost effectiveness of the program or intervention of focus was very important. And also 82% said that it was very important for the evidence to be presented in a brief and concise way. So on the other side, you see that the least frequently identified feature was that the implications of the research were politically feasible. So then when we stratify by political party, the significant differences here relate to these economic evaluation variables. So for both of these, Republicans were more likely than Democrats to say that providing information about budget impact and cost effectiveness were very important. So just a couple of things that we think are particularly relevant and important. Universities were not seen as a primary source for behavioral health research among legislators. And interestingly, among Republicans, the proportion of legislators that said that they would turn to universities, so 19%, was almost the same as the proportion that said they would turn to industry sources, so 16%. This finding that legislators are not turning to universities is consistent with prior research about health research in general, which suggests that legislators don't perceive the university researchers as having evidence that is relevant and timely to real-world policy decisions that they made. And so we see implications here for the research questions that behavioral health researchers are asking and how policy relevant they are and how timely they are. And another key point we think is important is that cost effectiveness data and data about budget impact were identified as very important most frequently, especially among Republicans. So to us, this really underscores the importance of conducting economic evaluations of behavioral health services and policy interventions and sending that information out to legislators. So this is what they want, and this is what is most likely to get their attention and get them engaged with the evidence, and thus make them more likely to use this evidence when they're making decisions. So just very quickly, some limitations of our study. As I said, the response rate of 16.4% is low. It's higher than other legislative surveys that have recently been conducted, but it's still much lower than what we had hoped for. Luckily, we had information about the non-respondents that allowed us to calculate and apply non-response weights that helped reduce the risk of non-response bias. And again, this study is limited to elected policymakers at the state level in the US. And so these results are not necessarily generalizable to elected policymakers in US Congress, at a federal level, or administrative policymakers in the executive branch of government at state levels who generally have more specialized knowledge about behavioral health issues. And lastly, social desirability response bias. So I showed that only 52% of legislators rated political feasibility as very important. And this might be the one variable where social desirability response bias, this might be the, the one variable where there might be a social desirability response bias where that might be perceived as kind of the wrong answer. So we're not really sure how much we trust this specific variable. And maybe political feasibility may be more important than legislators indicated in the survey. And so just to wrap things up, behavioral health researchers who want to influence legislators should disseminate their findings to diverse stakeholders and stakeholder groups, so specifically legislative staff, behavioral health advocacy organizations, and state behavioral health agencies over in the executive branch of government. And secondly, dissemination material should be concise and, when possible, contain information about cost effectiveness and budget impact. So thank you very much, and feel free to reach out to me or Dr. Jonathan Pirtle with any questions.
Can I restart that? Yeah. Hi, it's an honor to be here today. I'm Danielle Oh from the University of Colorado. I'm a general internist. So I'm here to talk about a pilot study. This is a mixed method evaluation of a pilot we did on tailored practice facilitation, which is an implementation strategy aimed to improve primary care provider management of patients with mental illness in a team-based setting. I am going to pretty much skip over my significance because the whole conference has been about it. And Dr. Unger this morning pretty much described it in further detail, but I will touch on a couple of things. So as was discussed this morning, much of the care of psychiatric illness is performed in primary care. And primary care providers do not feel prepared to do this. So that is the sort of root of this research. Team-based models of care also, as we're all very aware now, are highly efficacious, yet not well disseminated. And many times financial issues are cited as the cause. We heard this morning about the structural issues that the change required to institute collaborative care is significant. I have a focus on primary care providers with this stream of research because primary care providers are used to one-on-one care of their patients. They're slowly getting used to more team-based models of care, but although much of the collaborative care model is often implemented sort of above the level of provider, if you work at a larger institution like a Kaiser that decides to implement this across the board, in smaller practices or even university practices like my own, you have physician leaders who have to make the decision to implement this particular model. And in this model, primary care providers are not at the center. And that's a big shift. And so I argue there's some research for it, but mostly I argue that they have to be brought in as a stakeholder in this and buy into it if we're going to disseminate it. There is evidence that they face great challenges in working with healthcare teams, not so much teams, multidisciplinary teams, but teams where there are nurses, social workers, et cetera. So practice facilitation is a strategy that has been shown to work. So this is, I'm talking about traditional practice facilitation here, where you have often actually lay people who are trained in primary care practice improvement methods. Much of the patient-centered medical home is delivered. A practice facilitator comes in, they help the clinic work through whatever steps they need to work through to institute the changes to get their certification. This can happen at a very checkboxy level where you kind of do the things you need to do, but there isn't any kind of culture change that kind of happens in the clinic, or it can be done well. And they can begin to address deeper changes. Or lately, some practices seem to hire practice facilitators that stay on. So they're sort of working at multiple iterations of practice change. And so that does tend to get a little deeper. There's evidence they show increased adoption of practice change, because that's what they're doing. They're going in to help the practice institute these models. But, and some improved communication across different specialties. But they may not directly address, they are not designed to directly address relational characteristics. In their training, there's not training around the relational aspects of a team culture. So oftentimes teams get stuck with basics of not getting along or hierarchical dynamics. And that is not directly addressed in practice facilitation. They also do not have any specialty areas. They're purposely non-specialized, actually. So we developed the tailored practice facilitation, and we altered, or we played with this role of the practice facilitator in that in our model, the practice facilitator is a mental health specialist. In this particular pilot, our practice facilitator was a health psychologist, but it is designed that it could be a social worker, anyone with some practical training and practical experience in practicing in a primary care setting, behavioral health in a primary care setting. They then do training in traditional practice facilitation. So this role is a combined role in which essentially with the PCPs one-on-one, they essentially act almost like a clinical psychotherapist supervisor, shadowing. They provide education. They actually provide emotional support. I had one provider describe it as psychotherapy for the providers. Also communication skills. They also take a practice through quality improvement and do those very practical steps. So the structure of the model, let's see if this works. I'm scared to use it. Does this pointer work? No. Okay, never mind. Over here, the clinical supervision and coaching component. Oh, thanks. This component is actually the first component. So in the first half of the intervention, the whole intervention takes 8 weeks. So for the first 4 weeks, the practice facilitator shadows PCPs and their patients with complex, what we call complex patients, so patients with comorbid medical and mental illness. They see the patient and they have a brief debrief after each patient, in which time they may offer practical knowledge-based feedback. They may offer communication feedback. It really depends. And then in the second half is this practice change activity team, which is with representatives from the full clinic team. Also patient representatives are on that, where they work through a practice change activity, which is chosen from one aspect of collaborative care to increase the evidence base of the integrated model. This has to be done in a practice that already has some kind of integrated, but it could even be just co-located care. So we're trying to take it up. So we do practically move the clinics to a higher evidence base of whatever kind of integrated care they have. But then the practice facilitator also works on this relational the relational aspects of how the team works together. So we piloted this in 2 primary care clinics associated with the Safety Net Hospital in Denver, Colorado. PCPs were recruited for the full intervention, then clinic staff, leadership, patients for the PCAT only. And like I said, all clinics have to have a behavioral health provider in the clinic. Our primary measures, this was a pilot, were feasibility and acceptability, so ease of recruitment, implementation of the intervention, and acceptability. We used a modified 4-item measure of acceptability for the behavioral health interventions, which was on a 4-point Likert scale. We also used, our team had developed a team-based and mental illness management self-efficacy scales. I'm not going to go into that development here, but they were validated in a large survey of Colorado physicians, primary care, internal medicine physicians with high Cronbach alphas and nice correlation with other measures. We also used a modified communication skills, self-efficacy scale, mental illness knowledge and management instrument, attitude towards team-based care, you see it up there, and team climate inventory. These are all pre-validated measures. All of these are done on the PCPs themselves. For qualitative, we collected a vast amount of data, but for this evaluation, we only used the focus groups. We did focus groups separately with PCPs, staff and patients as a separate group, and then clinic leadership. So that was a total of 6 focus groups between the 2 clinics, and then using a semi-structured interview guide, these were all recorded and transcribed. The analysis was descriptive, pre-post evaluations of all the, using paired t-tests with a level of significance at 0.05. The qualitative analysis was a content analysis. And we use a team-based approach, and all the transcripts were double-coded. So we had, I'll speak to our recruitment in terms of feasibility. We actually over-recruited in both clinics, and we didn't ever send our emails to continue recruiting. We went on a visit, and so we had 18 providers in the 2 clinics. These are all for the PCPs, not for the full staff. You can see sort of representative of primary care, primarily female. It is Denver, Colorado, so it's a primarily Caucasian population with a little bit, 2 Hispanic providers and 3 non-white providers. We had 6 non-physician providers and a pretty even mix between family medicine, internal medicine, and a fairly even mix between less than 5 years of experience and greater than 5 years. So these acceptability survey results are for everyone who participated. So staff, administrators, anyone who was in the PCAT, essentially. So they were quite high. This was, again, a scale of 1 to 4 at 1 month, and at 6 months, they stayed high at 3.7. In terms of the pre-post changes in PCPs, we were not powered for this, as it was a pilot, so we were happily surprised to see that we did have a significant change in mental illness care self-efficacy. And I will say these scores are shifted to the right to begin with. So they start around 7. Doctors think highly of themselves. And so they shifted to about 8. So that is a decent effect size as well. And then I was actually quite surprised that the knowledge increased. Interestingly, like when we did that, when we validated the survey, knowledge, even though knowledge is thought not to actually be that important, even though all of our education is based on learning knowledge, turned out that knowledge was one of the factors that were important for mental illness care self-efficacy. So we did see this shift. The knowledge, the didactics were not, there was one didactic on how to treat bipolar disorder, but the didactics were much shorter, these brief interventions given. So the provider had, the practice facilitator had little handouts she could give. to providers of like how do you treat depression or medications to be given sort of on the spot after seeing patients. So I was happily surprised by that. You may notice attitude towards team-based care and team climate did not change. In terms of our focus groups, it was highly acceptable in these focus groups, really. I only have one quote up here. My mentors told me to take all the other ones down. But we got a lot of generally positive quotes. This one is from nurse leadership, which are sometimes the hardest to win over if you're in primary care. So it was a good use of our time, needed to be done. Negative, this was a provider saying that basically it was too many hours spent on the PCAT. The PCATs are done over lunch, 6 one-hour lunch sessions. And you can see down at the feasibility negative, it's also lunch was hard. So those are, and that's pretty much in all of it, the only negatives we got over the time involved with these lunch sessions. Positive feasibility, this provider is talking about how our practice facilitator worked through the project. It was difficult in the beginning and helped decide what we wanted to work on and basically getting them to an attainable project. So this is the project within the intervention. The impact on team care, staff commented a lot on how much they appreciated the changes to the team. So improved team functioning, this understanding of roles. The next one, hierarchy. A lot of the staff said that they had never sat down like that in an even keel. A lot of the activities are done so that actually the lowest person on the totem pole gets to speak first. The physician spoke last often. So bringing in the patient perspective, including all the voices. So in conclusion, we found this pilot highly feasible. We recruited more PCPs and staff than originally planned, and no major obstacles to implementation. Highly acceptable among PCPs, staff, clinic leadership. The coaching component, which is that one-on-one, was a higher value to PCPs than the PCAT, where they're all together as a group. Interestingly, I always get the feedback, PCPs aren't going to want to do this, it's going to interrupt their flow. And so that was sort of interesting. Anyway, so we feel that TPF has the potential to significantly impact outcomes for patients. Hopefully it's a method to disseminate more broadly models like collaborative care for depression. And I will say this was done with my K-23 funded by NIMH Health Services. And I don't know how to get out.
Hello, and thank you for sticking around till the end of a packed couple of days. My name is Amrita Bhatt. I'm from the University of Washington, and I'll be talking about longitudinal remote consultation, or LRC, for implementation of perinatal collaborative care. So it actually flows very nicely from your talk of practice facilitation, because this is an intervention-specific implementation strategy. Just give you a minute to look at that. So just kind of emphasizing that these are preliminary results, and I'll appreciate your feedback and your questions at the end of my presentation. Let me get on my soapbox for a minute here. I think it is important to get evidence-based treatment out to anyone with depression, But when you treat a mom with depression, a pregnant or postpartum mom with depression, you're getting a twofer, because you're treating the mother, but you're also preventing negative outcomes in her baby. So we know that children who are exposed to untreated maternal depression during pregnancy or postpartum have higher rates of failure to thrive, they have higher rates of developmental delay, and they have higher rates of emotional and behavioral disorders. So very important to treat moms with depression. But unfortunately, even in places where universal screening for perinatal depression is common, only about 20% of screen-positive women then follow up with mental health treatment. So one way to get treatment out to moms is collaborative care. And many of you in the room are familiar with this model of care. You spoke about it. If you were at Dr. Nutzer's talk this morning, you heard about it. So very briefly, this is team-based care, which is patient-centered, and it uses principles such as measurement-based treatment to target. The primary care physician or prenatal provider is closely associated with the treatment. The new role is that of the behavioral health care manager, who tracks improvement and who provides evidence-based therapy if indicated. And the psychiatric consultant may or may not have a direct assessment with the patient, but regularly meets with the care manager and reviews the entire caseload of patients. And that regularly scheduled meeting or systematic case review is key to the implementation of collaborative care. Now, this is backed by several years' worth of evidence. So I won't spend too much time discussing that. More recently, also, it's been shown to be effective in the perinatal period. This is from the Mom Care study by Nancy Groth. And in this perinatal collaborative care, using interpersonal therapy as the psychotherapy provided was compared with usual care. But what happens when we try to implement a complex intervention like this, which requires, as Jürgen was saying in the morning, several practice changes? There is high variability in how much uptake there is to collaborative care and how much fidelity there is in its implementation. And some of the barriers that we found are that there are limits to training and implementation support, which are always more readily available in randomized controlled trials, not so much in the real world. And unlike interventions which involve an individual provider, a multi-component intervention like collaborative care needs resources to support several different staff development. So that can be a barrier as well. The other thing is that we know that a one-time training does not work to change provider behavior, and we need ongoing or longitudinal support to be able to train someone to mastery. So LRC, or longitudinal remote consultation, evolved spontaneously during implementations of collaborative care in response to some of these barriers. So depending on which compilation of implementation strategies you're deriving from, you could call it an educate strategy, or you could call it a providing ongoing consultation strategy. And it maps on nicely to the interactive systems framework for implementation of innovations. So you see the support system, which is required for the delivery system, and at the interface is the evidence-based system for implementations, which includes tools, training and technical assistance, and quality improvement. So if you look at the support system, there is practice facilitation. There is also an intervention-specific support system. In this case, it's longitudinal remote consultation, because the longitudinal remote consultation focuses on the intervention, which is collaborative care, and it emphasizes that the team is trained to mastery in collaborative care. So what does LRC actually look like? There are a couple of us in this room who have provided longitudinal remote consultation. When I provide LRC to a clinic that's implementing collaborative care, I join the clinic's weekly systematic case review. So I join that meeting between the psychiatric consultant and the care manager in that particular clinic. I use video conferencing to do that, and that's good because it helps with this intervention being scalable, being able to have a centralized consultation service that can be delivered using video conferencing. So this is ongoing support. It's provided over a year. And we provide expert coaching, live observation, and performance feedback. And all the time, focusing on fidelity to the collaborative care model. It's important here to distinguish consultation from clinical supervision, because consultation is non-hierarchical, and the consultant doesn't have direct responsibility for the implementation of care. The consultee can accept or reject the consultant's suggestions. And here is the timeline of LRC that we've been using in some of our implementations. We provide 6 sessions biweekly in the first 1 to 3 months. I should clarify that we do recommend systematic case review in the clinic happens every week. It's just that we join the case review at this frequency. In months 4 to 6, we provide 3 monthly sessions. And in months 7 to 12, we provide 3 bi-monthly sessions. We could add additional 2 or 3 sessions depending on the need, depending on how the site is progressing in meeting the program level metrics or achievement of mastery. I thought I would share with you an actual LRC feedback form. I'm sorry if it's not very clear up there on the screen. But what happens is after we join a clinic in the systematic case review, we then share the feedback with them in this format, hopefully within 2 days of having joined them for the systematic case review. And usually each new LRC session begins with a reflection on the previous one using this form as a template. So should I dare try this? Maybe not. We all made the same mistake. So across the top, you'll see some of the program metrics that we focus on, which is number of contacts that the care manager has with the patient, and whether the psychiatric consultant is involved when the patient doesn't improve after 8 to 10 weeks in the program. We know that those are associated with patient outcomes. And then here is some description of the patients that were discussed and how much time was spent discussing each patient. So there's a 27-year-old primary gravida who was not responding to escitalopram. There's a 3-week postpartum mom who has psychosocial stressors, so that detail is on there. And down here is the qualitative feedback, mapping onto some of the key principles, the core principles of collaborative care. There is encouragement to the site to not only enroll patients on the registry, but also put patients on relapse prevention plans. There is a congratulations to them for having good number of care manager contacts. And there is a gentle nudge to get psychiatric consultant opinion on patients that are not improving. So that is LRC feedback form. This, I've removed identifying information, of course, but this was a clinic in California. They had a really strong collaborative care team. They even had an obstetrician who was very excited about this model of care and even made an attempt to join the weekly systematic case reviews. Out of the 10 times that I joined their case review, 8 of the time she was paged out from labor and delivery within 5 minutes of having come in there. But I thought it was really nice that she made the attempt. This is another part of the LRC assessment, which is assessment of mastery in 3 different levels, developing, partial, or complete. And this could be part of the decision to give those additional LRC sessions. It could also be a key measure to quantitatively assess the mechanism which is related to patient outcomes. Coming to the results of the study that I'm going to present, this is a multi-state randomized trial assessing implementation strategies. Ian Bennett's the PI. He's, I think, in the adjacent room talking about the electronic registry that was built to support this implementation. These are, like I said earlier, preliminary results of 3 out of an expected 10 that will be randomized to LRC. We used the feedback forms, one of which I shared with you, to do a content analysis of patient-related discussions and LRC consultant qualitative feedback. An independent investigator conducted semi-structured interviews with the collaborative care team members in each of the clinics using the CFIR, or Consolidated Framework for Implementation Research. And we used the content of those interviews to assess the acceptability of LRC. And we used the LRC feedback forms again to look at the number of sessions, adherence to schedule, and collaborative care team completeness. Here are some of the results. 26 LRC sessions were conducted with the 3 clinics over a period of 10 months. 67% of them occurred on the recommended schedule. As far as completeness of collaborative care team, one clinic had a complete team in place for the entire duration of the implementation. One of them didn't quite get to complete their team, and one of them had a complete team in place for half of the LRC sessions, and the complete team is the psychiatric consultant and the care manager. Looking at the consultant feedback, there were 150 discrete consultant suggestions in those categories, some of which I showed you in the feedback form in terms of engaging patients, enrolling patients, and keeping an eye out on clinical outcomes. You can see here that a majority of the feedback was regarding enrollment and engagement. And this might be reflective of the fact that the clinics, at least these 3 clinics, some of them were slow to implement and were in the earlier stages of implementation, so focusing on enrollment and engagement for the LRC sessions. Patient-related discussions, again, focused on engaging individual patients. 26% of them addressed diagnostic questions, and the others addressed issues such as psychosocial complexity. And looking at participant feedback, it was well accepted by participants. It mirrored other investigations into what exactly consultation does in terms of liking the connectedness with the consultant, for example. The clinics perceived that LRC supported better patient care. One of the quotes was, 2 heads are better than 1, and LRC shows me things I don't think about. They did find some challenges with scheduling the LRC sessions, which was understandable with them having in their clinic to coordinate the schedules of the psychiatric consultant and the care manager, and then the LRC consultant having to be available to call in at that time. And they found challenges with getting the reports back. So what will we do with these findings? So we found that LRC feedback did consistently address the key principles of effective population-based mental health care. So we look forward to collecting the complete data from this trial and look at association with implementation and patient outcomes. We found that the sites only partially adhered to the LRC schedule. So one option would be to revise the LRC timeline to make it more appropriate for slow implementers. So maybe start with the LRC a little later in the process. Or incentivize participation in LRC. In cases where there are incomplete collaborative care teams or there is turnover, perhaps the LRC consultant could then step in as a psychiatric consultant for that period of time. That's one suggestion. And we are definitely looking at modifying the schedule of LRC sessions and how we share the reports with the sites. I want to thank my co-authors on this presentation and funders. Thanks.
Wow, that was great, and we still have quite a few folks here. This is wonderful. I'd like to go ahead and open it up to any questions that folks have. As you can tell, we had a range of different topics that folks covered, from all the way from diffusion of medication, of mental health treatment approaches, medication adherence, of course, translating behavioral health, research into policy, pilot testing of the facilitation approach, and identifying a lot of barriers. In fact, my question that I have is, if you could pick one barrier that you could incentivize, what would that be and how might that look? So that you could incentivize the solution to address. But why don't you hang on to that one? I see someone's come up since I raised that one. We'd love to hear your question.
This is for Dr. Loeb. So in your pilot, you targeted primary care clinics that already had a mental health provider in it. So what did you notice were the key ways that these mental health providers were utilized differently after the intervention?
So at one of the clinics, the thing I can't talk about that was actually most fascinating, but because it was only 2 clinics in a pilot, the cultures were completely fascinating. It was like, it was very interesting. But one of the clinics, there was there were strong problems between, in communication between the PCPs and the behavioral health specialists. The model was that ideally they would see patients with warm handoffs and they would do brief interventions, sort of classic integrated care, but the communication had completely actually broken down in this particular clinic. And so the intervention they ended up working on was just that, trying to have more same day, more warm handoff, more communication. And that was still happening last time we checked in. So it was working with the model they actually had, but that had completely broken down because of this. It's a clinic in which primary care providers actually come in for only a few days a week. They're not there all the time, and so it was like family therapy in a way. But we did do a specific change.
Some parallel processes going on there. Please, yeah.
This question is for Catherine. So two of the sources of information that you highlighted, advocacy organizations and industry, those seem like both sectors that employ lobbyists. I wonder if you have any thoughts on what role lobbyists play in getting research information to legislators.
Yeah, I mean, that's a great, I think this is working. I think that's a great question. And I think it's definitely something, like another group, along with legislative aides, that I think we should be exploring kind of their role in connecting researchers and policymakers. So I was in your presentation yesterday as well. And I do feel like they are kind of in that, they're one of those players that are in that mediator role. And so, yeah, I think that's a great question. I think we'd love to explore it.
There's another implementation researcher coming to the microphone.
Oh, yeah. So this question's for Martha. Do you think that medication non-adherence is like almost kind of like a chronic condition? Like, do you anticipate that the intervention that you've developed and tested is something that's like then going to need to be like repeated in a year, or like how do you like? Because to me, it's almost like a risk factor. It's like obesity. It's like smoking or something that could potentially continue and need work over time.
Right. So our outcomes were 6 months, and actually. You know, we didn't see the symptom change in our RCT because people started off with fairly low. But in pilot, what we saw is that it takes a while for functional and symptom and all those other things to kind of come online once you improve treatment adherence. But you know, in the comment they made at the end that this is not an event, so you know, people have to make a decision at least once a day, sometimes multiple times a day, whether they're going to take a medicine, right? In addition to all that other competing stuff. So I believe that you have to build this in. Our CAE intervention is brief, so it's 5 sessions. It's done over the course of 6 to 8 weeks, fairly low burden. And I loved your question, Denny. Like, what would be the thing that that I think that if I could have my wish list, right? What I notice, I don't think we incentivize patients enough to get engaged in their own care, whether it's treatment adherence or health decisions. And you could say, well, virtue is its own reward, and good health is your reward to taking care of your health. But I think we can do better than that, and I think there's enough evidence to suggest that there's other ways to incentivize outcomes, and we pay providers and we pay administrators, but I think we need to look at better ways of incentivizing patients and providing support on a longitudinal basis.
What about the non-psychiatric medication? Like, did you look at that?
The question is, what about the non-psychiatric medication? Okay.
Yeah, so we did look at that, and I'm working with a colleague at Case Western, Dr. Jennifer Levin, who's got actually an R21 from NIDDK to look at bipolar patients with poorly controlled hypertension, and that's like a huge issue with tremendous medical and kind of economic burden. And these approaches can work with the non-psychotropics as well. What we did tend to see is that people do some picking and choosing, but generally once you can start to encourage adherence and engagement, it tends to have spillover effect. So I don't think this is you know, a little niche market. I think this is something we can definitely expand. And we're doing this with schizophrenia, so there's other really interesting things. We're doing this, I have a Fogarty grant that's funded in Tanzania, and we're adding the CAE approach to the administration of long-acting injectable antipsychotics. So I think there's lots of opportunities to think about how this could be implemented into care plans.
Oh, yes. Andrea.
What about that? Congratulations, it was a really nice panel, very diverse. I would like to ask a question about the legislators that you were, I thought it was very interesting data. And I was thinking, coming from you, your experience, what would NIH could do for that? In a sense, to the researchers to provide information outside, and also for us in NIH providing to the legislators. What are thoughts on that?
Yeah, I mean, I think that's a great question. I think there's always a dissemination plan that's kind of part of grants and grant writing, and I think one way to kind of bridge this gap and incorporate what we're seeing, this need for concise and brief delivery of findings, might be to kind of shift that dissemination requirement or adapt that so that instead of just kind of typical means of dissemination like journals or conferences, but adding another component that's really focused on lay audiences or policymakers or educators, et cetera. So in my opinion, that's the one big clear thing that could be done to incentivize this and kind of work to engage other audiences and in evidence-based practice and research.
And if it's all right, I'll just ask one quick question of Amrita. You were the one in, I think, one of your last slides that talked about as you implement a complex model, collaborative care, how, what are the unique barriers? And you listed a number of them, and you also put down incentivizing. And I wondered if you had any more thoughts that you'd like to share about.
That's a preliminary suggestion that we came up with when we think about how do we encourage these providers to have systematic case reviews. One thing, of course, is knowing that systematic case review is associated with patient outcomes, and emphasizing that with the findings that we have could help them actually meet for systematic case review regularly, and then LRC would automatically follow. If part of the payment for the care that they're providing is linked to continuing training in some way, that might help them be more motivated to come in. Yeah.
That's great. Thank you all. Fantastic presentations. And thank you for staying with us. If you have time, I guess there's some kind of informal happy hour down the hall here. We'd love to have you join us. And I hope you've had a great time these last 2 days, and we will hope to see you in 2020 at the 25th Mental Health Services Research Conference. Great, great.